Hello, my name is Amanda Oleslager. I'm a student with BCIT doing the Breastfeeding Experience Nursing course, and today I will be talking about the breastfeeding challenges of flat nipples and jaundice.
I will be using Gillespie and Peterson's situated decision-making framework to guide my presentation. This framework helps the nurse to fully understand a patient's situation with the objective of assisting the nurse in making a timely and appropriate clinical decision. What is important to remember with any barrier or challenge faced with breastfeeding is the importance of the 3 rules. First rule, feed the baby. Ensure that the infant is fed, producing the acceptable number of dirty and wet diapers, gaining appropriate weight and not hypoglycemic. Number 2, move the milk. If the mother or baby dyad are learning to breastfeed and have yet to establish an effective latch, it is important that the woman continues to move the milk, either through manual expression or electric pump. This helps to establish and maintain her milk supply. The third rule is to help the mother and baby learn to latch appropriately and breastfeed effectively. The maternal barrier to breastfeeding that I will discuss is flat or inverted nipples. There are many different breast and nipple shapes, most of which do not cause a problem with breastfeeding. A nipple that is flat or inverted, however, can be a challenge when latching baby. A nipple that does not become erect when stimulated is considered flat. And when the areola is compressed, a nipple that actually inverts or disappears is considered inverted. Very often this is caused by adhesions holding the nipple to underlying breast tissue. Though babies do not nipple feed directly, the nipple plays an important role in stimulating the sucking reflex, and some babies who have additional barriers to breastfeeding, like tongue tie, jaw issues, prematurity, and so on, will have a harder time latching. However, if a baby is able to get a good mouthful of areolar breast tissue, and with practice, the pair very well may be able to breastfeed successfully. And in actuality, inverted or flat nipples cause very little problem in the majority of women. The first steps to successful breastfeeding for every mother is skin-to-skin contact as soon after the birth as possible, and to initiate breastfeeding within the first hour of life. There are a few techniques which are helpful to women with inverted or flat nipples, and there are other techniques which are considered to be controversial with their usage. Using nipple stimulation and adhesion breaking techniques such as Hoffman's techniques, seen in the bottom left picture, can help to break adhesions holding nipples in and help to soften breast tissue in preparation for feeding. These techniques can also be done prior to birth in anticipation for breastfeeding. Many women believe that using an electric or manual pump for a few minutes before attempting to latch helps to bring out the nipple and soften tissue. The Averted Nipple Enhancer was designed by lactation consultants and uses gentle suction to bring the nipple out. Devices such as nipple or breast shields should be used cautiously and with the help and recommendation of a professional, and as a last resort. If used correctly, they can help prevent soreness and help baby latch. If used incorrectly or at the wrong time, they can cause nipple confusion, prevent effective latch, decrease nipple stimulation, and ultimately decrease or prevent establishing a milk supply. They can also cause skin breakdown. Effective milk transfer to the baby should be closely monitored if a nipple shield or breast shield are being used. It is important for the nurse to listen to all the mother's concerns and assess her breasts often, looking for signs of cracking or nipple damage, as well as signs of infection or blocked milk ducts. And as the mother's milk supply becomes established, engorgement should also be assessed for and treated appropriately. It is important for the nurse to encourage the woman and affirm her in her perseverance. Throughout the process of learning to breastfeed her baby, the mother will go through a range of emotions. Additional support for a longer period, past the time of 2 to 3 days in hospital, is shown to increase the length of time a mother will breastfeed, and thus pass on all the goodness of her breast milk to her baby and establish bonding and attachment. The nurse may need to put in a request for a lactation consultant or a public health nurse to meet with the woman in her home. Women with flat or inverted nipples are able to breastfeed successfully with practice and support. Nurses should enable women to sustain exclusive breastfeeding for 6 months, and then with complementary foods continue breastfeeding for as long as the dyad choose. Using nipple stimulation or a breast pump before feeding, Hoffman techniques or averted nipple enhancers, or nipple shields can help to bring out nipples and assist in obtaining a deep latch for the baby. And lastly, support outside the hospital should be considered for all women, and especially those with specific challenges sooner rather than later. Support sources such as lactation consultants, mother support groups, or public health nurses are all beneficial. The infant illness that I will be discussing is jaundice. Jaundice is a relatively common condition, with about 60% of term and 80% of preterm infants developing the condition within the first week of life. Jaundice, or hyperbilirubinemia, is an excess of bilirubin in the bloodstream. Bilirubin is a product from the breakdown of red blood cells. Newborns are at risk for this because at birth they have a higher level of red blood cells, which have a short lifespan. Broken down red blood cells can accumulate for many different reasons, but because there is an excess of bilirubin in the blood, the liver, which is responsible for processing the bilirubin into a form that can be excreted, is unable to keep up. And as a result, bilirubin is left to recirculate the body, producing high serum levels. Babies can develop early onset or breastfeeding-associated jaundice, which is caused by insufficient feeding and infrequent stooling. This develops early in life, between 2 to 5 days of age, as the mother's milk may not yet be established and the quantity that the baby receives is low. Colostrum is known to have laxative properties, and the act of feeding produces peristalsis of the intestines, assisting with the passage of meconium. With jaundice, the lack of stools ultimately prevents bilirubin from being excreted. Other causes of jaundice include hemorrhage, sepsis, viral or bacterial infections, liver malfunction, enzyme deficiency, and sickle cell anemia. There are many different signs and symptoms of jaundice. Some of the trademark ones, however, are yellow discoloration of the skin and sclera, sleepiness, brown urine, and high blood serum levels of bilirubin. The result of untreated jaundice is neurotoxicity in the form of bilirubin encephalopathy, which can manifest in symptoms such as a high-pitched cry, poor sucking or feeding, backward arching of the neck and body, fever, seizures, vomiting, a permanent upward gaze, and hearing loss. During the first few days of life while still in hospital, part of the nurse's assessment is checking for jaundice. This is done primarily through assessing skin color by gently pressing on the baby's forehead or nose in natural light. The blanching will appear yellow if jaundice is present, or slightly lighter than skin tone, or white if jaundice is not present. Assessment of feeds is noted, including evidence of milk transfer, counting of meconium diapers, and readings from the transcutaneous bilirubinometer after 24 hours of age. If jaundice is suspected, serum bilirubin levels should be ordered, as this is considered to be the gold standard in diagnosing jaundice. Serum levels and transcutaneous bilirubinometer readings are charted by hours or days of life, which then determine the degree of jaundice. First-line treatment for infants with mild jaundice is to increase feeds. Whether this is done by putting baby to breast more often or for longer periods of time, or if mom has to pump or hand express and cup feed baby initially until her milk supply is established, this is done first. Treatment for jaundice should not interrupt or postpone breastfeeding. Breastfeeding should be continued and increased if possible. Another common treatment for jaundice is phototherapy in an isolette. The phototherapy uses a special artificial blue light which alters bilirubin so it can be excreted in urine and stool. Fiber optic pads can be used on their own or in conjunction with phototherapy. Benefits to the fiber optic pads are that they make the infant more portable for breastfeeding purposes without interrupting the therapy. At any point, if serum bilirubin levels are measured to be above 25 milligrams per deciliter, this is considered a medical emergency, and the infant should be evaluated immediately for an exchange transfusion. It is important for mothers of jaundice babies to continue to breastfeed and to ensure she is putting baby to breast 8 to 12 times within a 24-hour period. A mother who has inverted or flat nipples and is having a hard time latching may need to hand express or pump some milk and cup or syringe feed her baby just until the jaundice is resolved or she has successfully latched and demonstrated adequate milk transfer. This is identified through visualization of a deep latch, audible sucking and swallowing sounds, an appropriate number of wet or soiled diapers, baby is gaining weight appropriately, mother feels the letdown reflex, and breasts are emptying and filling, as well as baby appears satisfied after feeding. Adequate feedings will help baby clear the bilirubin from its system and increase stools, and by hand expressing or pumping, the mother may be able to draw out her nipples in order to obtain a deeper latch and encourage a healthy milk supply, with the expectation that with proper support, the pair will be able to exclusively breastfeed successfully for many months or years to come. If possible, the nurse should provide immediate skin-to-skin contact for mother and baby and facilitate an environment that is quiet and peaceful for the first feed. This should ideally happen within the first hour of life. An early and often approach can help establish breastfeeding and prevent jaundice. Jaundice that is not treated appropriately can be life-threatening. Thorough assessment by the nurse and teaching for the parents through a family-centered approach can catch signs of jaundice early. Breastfeeding should not be interrupted during treatment for jaundice, and breast milk should be the only source of fluid and nutrients needed by the baby. The nurse should ensure the baby is receiving enough breast milk through thorough assessment and measurement if necessary in the case that breastfeeding is not fully established. This concludes my presentation. Thank you for watching.